or it is foolproof. So next talk is on Operation Theatre Surveillance by Dr. Samrat CHATTERJEE. He is the Infection Control Committee Chairman in our hospital, which is runs under the NABH. So his in-depth knowledge about the surveillance part, how to validate the processes which has been done. So over to Dr. Samrat.
So I would like to at the outset thank AIOS and APO for accepting our instruction course, and thank you Dr. Meir for the generous introduction. So there's no financial interest in any of the material that you see out here. So we all know that we need to prevent post-operative site infection and for ophthalmology, acute endophthalmitis, and for that is the primary goal of entire theatre. And as you have seen that it starts not after the theatre is built, but it starts before the theatre in designing and also on the general practices. So surveillance is a continuous process, and when you act upon the information and analysis of the data that you get from your monitoring, that becomes surveillance. So surveillance is an active role that an ophthalmic surgeon has in preventing acute postoperative endophthalmitis. So whenever you have a new facility, one should do an OR surveillance on day 1, day 2, day 3 and day 4. So this cleaning and fumigation should be done and you should get these 3 non-significant reports, and I'll tell you what a non-significant report is. But once the facility is built or after, then it should be done. There's no fixed guidelines for it. So depending upon the resources that you have, it can be an expensive process. You can do it either fortnightly or at least once a month. So that is important, to do it once a month in an existing facility. So OR surveillance can be done by anybody. You can train your OT nurse, OT technician to perform, or if you have access to a microbiology lab, then their staff can also do the surveillance. For the surveillance, you need sterile swabs that you can see out here. Then you need a liquid media. Then you need some solid plate like blood agar, chocolate agar and SDA, and you also need some biomonitors. So the sample collection is usually done the previous day. One does the deep cleaning and fumigation if you are doing fumigation, and next day early morning before the OT starts, before people enter the OT, you need to do the sample collection, and you need to label all the sterile swabs that you take, and then you need to moisten the dry cotton sterile swab in the liquid media and then use it to take the sample like it is shown out here. So you can see that you take it from the wall. Which wall? You don't need to take it from all the 4 walls. You can take it from the wall or the head end from the surgeon. Secondly, you need to take it from your AC vents and AC ducts, from the head end of the OT table, then from the handles, from your OT trolleys, and where you are cleaning your hands, you need to take the midstream from your water supply, water source. There is also, you need to monitor the air also, the air quality. So air quality, there are some specific equipments out here, but most commonly that is done in most of the center is this settle plate method. So before you start doing, after you have taken all the swabs, what you do is you open a petri dish of blood agar and seborrheic dextrose agar that you can get from your laboratory, and you just keep it open for half an hour. And after half an hour you close it, and then you can start the OT, your routine OT. There are some specific formulae for this thing, calculating your bacteria carrying particle load, but the most dictum is that if you have more than 10 bacterial colonies in your solid media plate, it is significant, and if you have even a single fungal colony, that is significant. So more than 10 bacterial colonies and 1 fungal colony, that is the dictum or the rule of the thumb that you need to follow. Then when these samples are collected, of course this part you are not directly involved, it's your the laboratory services, so they will incubate it in proper temperature and air system. Then Dr. Anupam had briefly alluded to you about the indicators. Now there are 6 classes of indicators, class 1, 2, 3, 4, 5, 6. It doesn't mean that 6 is better than 1. Each of these measures some specific processes. Of these, you need to have three. Three is the minimum. First is this signal lock or indicator, which we all are familiar with. It just turns color and tells us that it has been exposed to some steam or something like that. The second is you need to have the Bowie-Dick. This is the Bowie-Dick. This is a Bowie-Dick that you get, and after sterilization, it changes color. If it doesn't change color, that means the steam penetration within that load is inadequate. And then you need to have either a 5 or class 6, because that assesses and validates your cycle time of your sterilizer. So, and these are very simple to interpret, like in this class 5 you can just see that there is a gray line. If the gray line goes into the green zone, that is the pass zone, that means your sterile process is effective. And these are the class 6. So, you need to have 1, this is mandatory, this is mandatory, and this. So, this goes for each equipment, even a single pack of a swab or a reusable blade, you put this. This goes for the entire packet. So, if you have a tray, you put this on it, and this you do once a day. Once a day in the morning, you run the Bowie-Dick. That it comes in a pack. You put it in your sterilizer without anything else, without any other load, and you let the sterilizer complete its cycle. Take it out, remove the sheets of paper, and then see whether the color has changed. If the color has changed, that means that machine, that autoclave is good enough for the entire day. Then you have biomonitors. So, you need to also to do a biomonitor test, and this doesn't need to be done daily. You do it once a week. So, if you have a EO gas also, so the EO gas and the steam autoclaves, they have different biomonitors. And both these biomonitors are placed where? They are placed at the most central part of the load, where the steam or some steam and would would have the most difficulty in penetration. And once you put this vial inside the load, get the sterilization completed, and you take it out, then there is a small ampule out there. So, you see this blue media, so that is the media, and inside the media there is a plastic ampule, a glass ampule. So, you squeeze on the glass ampule, and the spores that are present within the glass ampule will come into the media. If your sterilization process is good, that means all the spores would have been killed. So, there will not be any change in this media indicator. However, if there is a lapse in this sterilization, the pressure has not reached, or if the steam has not penetrated, then the spores would not die. So, once you crush it and incubate it, then the spores would turn into bacteria, and then you would get a color change. So, you just need to see for the color change. However, just doing this is not enough. Although this is not the microbiological surveillance, this is a operation room surveillance. So, you need to check all your equipments, like you go to the your block room, see if the drugs that are there have not expired. Each of us should have a use by date policy. So, see if for example, Apidin and all, you should finish it off in 24 hours. So, see, check all the dates, expiry dates, when it has been opened. Then you go into the operation room, and then you check for its systems. Go into the sterilization room, look at all these records, the biomonitor, the indicators, whether they have changed color, whether your OT staff is making a note of the the load, that each load contains which trays, and which tray has gone to which OT if you have more than one OT. So, all those things need to be done, and you need to physically inspect your the area, see if some of these windows or things, they don't, the linings, the silicone linings that are there, if they have not come out, if there is a seepage somewhere, a damp spot somewhere. So, this needs to be a daily process, and if you are in a single setup, you are the person responsible, you are the master of the ship, and this you have built. So, you are responsible for it, and you need to see it every day, like we check our own home. As a professional, our OT theatre is part of our home, the sanctum sanctorum. And then you need to maintain all these registers. They should be kept, so you need to monitor it, and you need, so this has a record, and then it can tell you about the pattern of how your systems are working. If you are the sole person, you don't need a committee, but it is better. But if you have multiple people, you should have a committee which should take decisions whether you need to change from one sterilization system to the other, change a disinfectant. If a disinfectant is out of the market, then other substitute. If you are getting more number of bacterial colonies, try to find out a source. So if you have 2 or 3 people in the community, the surgeon, the administrative head, and a microbiologist, it helps you to identify any lapse in your system. So the take home message is that surveillance is a daily business for us. Like we come to the OT, so you should have someone do a daily surveillance. If you do the surveillance, then whatever processes you had implemented you'd be sure that they are being carried out. And as the first picture, most of you have not seen the first picture, that post-operative endophthalmitis, you can prevent that. Thank you.